morning everybody, and welcome to the Friday of our learning week. Welcome to this morning's session, which is MDT decision making, the Emperor's new clothes. So with no further ado, it gives me great pleasure to welcome David Hamilton, who is a consultant in head and neck surgery at the Freeman Hospital. I hope you enjoy this session. I've actually been part of this session before and enjoyed every minute, so I hope you all get enjoyment today. Welcome Winnie.
Thank you. Hello everybody, my name's David Hamilton. So my middle name is Winston, hence the name Winnie, and that's what I tend to get called. So I'm in a slightly bizarre situation in that I'm now talking to you from my front room, but I've put on. I presume you can all hear me all right, can't you? Thumbs up for you. You can hear me good. So you can see that we've got a Christmas tree to try and give us a bit of Christmas spirit. So I don't know if I'll talk for the whole hour, but I will see. We'll see how things go. Send in questions as it goes along. I've actually got the question bar up here on another screen, which is why I'm looking down and up. So feel free to put questions or comments or whatever you want in, and we'll tackle them as we go. So this talk is based on quite a lot of different pieces of work that I've done over the years. I'm a consultant in ENT with an interest in head and neck cancer, and I spend most of my days treating patients with head and neck cancer, making decisions about how to treat them, and also reassuring other patients that they don't have it. And it means that I spend a lot of time in a multidisciplinary team, and I spend a lot of time speaking to patients about decisions. Decision making in head and neck cancer is particularly difficult. I'm sure every clinician says that, because we all like to think that our job is really important, don't we? But I actually think that head and neck cancer decision making is uniquely difficult. But in that way, it's a very good model for looking at how we should involve patients in decisions. So you'll see I started off the very first word of the entire presentation is MDT decision making, which is starting off with an acronym. Terrible. There's one thing I hate, it's TLAs, 3-letter acronyms. So I can't hear you, but I imagine there's oh, I can't. I imagine that you're all rolling with laughter at that little joke. So multidisciplinary team. Some of you may be part of one. Some of you may never have heard of one. Some of you may get the outputs of these sorts of teams. What they are a group of people who meet in a room to discuss a particular disease area. They're usually made up of one or more surgeons of different flavours. If it's a cancer MDT, then an oncologist, and then pathologist who will report any slides of histology and that sort of thing. Radiologist to show us the scans and to talk us through them, and then a number of allied healthcare professionals depending on the disease area. In head and neck cancer, it's made up of speech and language therapists, the allied healthcare professionals, mainly speech and language therapists, dietitians, clinical nurse specialists, because a lot of our patients have problems with their eating and drinking. And students of each of those specialities, administrative support. It can end up with about 40 people in a room. So it's a lot of people talking about a patient. The patients generally are brought in as a list and presented to the group, and then the group discuss their case. Now, the patient isn't present usually, which seems odd, and we'll talk about the implications of that soon. But on the whole, patients aren't present at MDTs. It's a reasonably business-like meeting. This is an American one probably, because for one they've got look like they've got free coffee. You don't get that at the NHS anymore. And you often have a big screen up to show scans and that sort of thing. So the multidisciplinary team, that's what we're talking about now. This is the sort of time I'd turn to the audience and say, how much do you think it costs? Because there's a lot of people to get all in the room at the same time. They're there for about, well, anywhere between 1 hour and 3 hours, and they've all got to prepare for that meeting, which takes probably another, depending on their speciality, another 2 hours of preparation time. So it's a hell of a lot of expertise in the same room at the same time. If you believe the Daily Mail, then these consultants are paid a huge amount of money. I don't know any of them, but apparently they are. So it costs per year for all cancer MDTs £100 million, roughly. Obviously, that's a reasonably estimated figure, but which may seem to you like a lot of money. I don't know. It depends where the angle you've come in at this from. I think personally, for curing all of cancer or discussing all of cancer in the UK, it's not too bad. I mean, look at this guy. This is Neymar, who was bought by Paris Saint-Germain for £200 million. So £100 million. That would get you Neymar's legs, which is quite a good deal, I think. Discussing all cancer in the UK for for a whole year, for the whole of the UK, for a set of legs isn't too bad. Now, for all that money, does the MDT change things? That's the first thing. If we discuss a cancer through an MDT or a disease through an MDT, do we make things better? Does getting all this expertise into the same room at the same time improve outcomes? Well, it depends which outcome you look at. Survival is the one in cancer, and this is cancer I'm going to be concentrating on the most during this presentation. Survival is very difficult to prove if MDTs improve survival, because it's very rare that that an MDT is started in an area without other changes as well. It's usually combined with some other centralization of care, some other process changes, or other changes in temporal trends, so improvements in cancer care. And because of that, it's difficult to say which aspect of those changes has led to an improvement, if there's been one. The best demonstration of a possible survival benefit was a trial done in Glasgow. One city divided in half, and breast cancer on one side and MDT was introduced on one side of the city, and on the other side it wasn't yet. And they found that the side of the city where when they adjusted for all the confounding factors, they found that survival actually increased in the patients who went through an MDT. That's the only demonstration I found that shows that an MDT might improve survival. But if it does or it doesn't improve survival, that's not the only outcome we care about. We obviously do care quite strongly about survival, but it's not the only thing that you're treating cancer for. Generally, there's reasonable amount of indication that it increases your recruitment to randomized controlled trials and any sort of trials, because the people in the MDT are aware of these trials and able to direct the appropriate patients the right way. This is a head and neck paper. It improves adherence to best practice, which means that all the patients are staged appropriately. They have the right scans at the right time. They have for example, their chest staged if they've got a cancer of their throat, or they each have a tumor nodal metastasis stage assigned, or they have all the tumor markers done, or the most recent and modern tests are done for every patient, meaning that the practice stays modern and up to date. They're popular. That's probably one of the main reasons why they're so widespread. Patients love them, and professionals love them on the whole. In particular, professionals, and you can see why, because it's an opportunity once a week or once a month to sit for 2 hours with your colleagues whose opinion you respect and value, and talk to them about your difficult cases. And those of you clinicians out there in the ether that I'm speaking to will know that your difficult cases are the ones that keep you awake at night. And actually to be able to sit down and go through them in the finest detail with your colleagues is hugely beneficial. And let's be honest, sitting, drinking coffee and going through all our cases and making sure we're doing everything right is just a nice way of doing things. So it is a popular process to go through. It's popular with patients as well, generally, because it's seen as expertise. It's a group of expertise. And so why wouldn't that be good? You know, if you want something doing to you, you want the best experts to do it. And therefore, this is seen as an expert panel. So who's the loser? So after all that, the only real conclusion after looking through this literature a few years ago now, to be honest, but is that MDTs make different decisions to individual clinicians. Now, as to whether those decisions are better or not, depends on how you define how good a decision is. Decisions are difficult to judge as to how good they are. But really, all we can actually say is MDTs make different decisions to individual clinicians. When it comes to better or worse decisions, it's very difficult to judge whether you value a decision as being good or bad. Most of us judge the quality of a decision based on an outcome. For example, is this a good decision? Those guys jumping out of that plane at the point where they jump out don't know the outcome of their endeavours. So really, the quality of their decision should be assessed at this point. But we tend to assess decisions by their outcome. This is a good outcome. Yes, that was a good decision. He's having a time of his life. This was a bad outcome. He's plummeting to his certain death. Well, I suppose. Is this a good decision? Some of you may think, no, awful. Some of you may think, wonderful, best decision I've ever made. And this person would agree with you. Best decision I've ever made. These three probably wouldn't. So I think the thing I'm trying to say from these slides is that judging a decision by its outcome is in some ways problematic. Essentially, what I'm trying to say at this point is that making a decision, you're basing it on information which you have to hand at the time. And obviously that information changes. But just because a decision has a bad outcome doesn't necessarily mean that the decision process was flawed. You can have a very good decision process with information given to the right parties at the right time and shared between people, but that doesn't mean that the treatment is necessarily going to go well. Now, so I hope I'm trying to get across that judging the quality of the decision purely on the outcome can be problematic. So if we look at the MDT members, the people who are on an MDT, this is quite a large study done in 2009 of more than 2,000 MDT members, and they felt that they enjoyed it. You know, they liked the support of the other people who came to the MDT. It increased their job satisfaction. So the same with this. The second study there is a qualitative study of people professionals who attend an MDT. And the other thing is, if we're going to save money in in cancer, then perhaps getting rid of an MDT isn't the best way of doing it. I mean, I thought that this poster here I saw near my house, food sticking when you swallow could be a sign of cancer. I felt like graffitiing, but it probably isn't, because it usually isn't. So the feeling of a lump in throat is very rarely feeling of lumpy throat is very rarely cancer. So if we're going to save some money by getting rid of MDTs, perhaps we should change the posters first. I don't know. But the other thing to say is that medical decision making is also modernising, and we are no longer in a position where we make decisions in a room for a patient and then deliver that to them. This is a GMC document. Those of you doctors will know the General Medical Council, who governs most of our behaviour. And this is a pamphlet they published in 2008, Consent, Patients and Doctors Making Decisions Together. So that we should be making decisions together with our patients, not for our patients, and then delivering verdicts to them. This is a BMJ, which have always been very supportive of shared decision making and patient involvement and decision. Welcome to the century of the patient, and the government as well have latched onto this in terms of the no decision about me without me. It's a very popular and worthwhile movement, shared decision making and involving patients in decisions. It's something that we all try to do as part of our practice as individual clinicians. The question is, how does that marry up with MDT decision making? Because MDT decision making doesn't have the patient in the room. So how do you share that complex decision process with the patient? Now, a lot of people, the reason I'm showing you a plumber, a lot of people, when I was doing my PhD looking at shared decision making in head and neck cancer, told me that that really, you get a panel of experts together and you want to know their verdict. So this is a plumber. When he comes to your house, you don't want to know how your central heating works. You just want him to fix it. And that's how a lot of people see an MDT. It's a group of experts, and they're there and they've got a lot of expertise in, for example, cancer or whatever the disease area is. And you want to hear what they've got to say. So if the plumber comes around and starts telling you about your overhead manifold sprocket and the bleeding of your radiators and all that sort of stuff, then you just get lost and you say, well, it's fine, just do whatever. Because we want the plumber to fix our central heating. That's what he's there for. Now, the flip side of that is, actually, if the plumber is standing there telling us about the overhead manifold sprockets and the way our push valves work and stopcocks and that sort of stuff, then perhaps he's giving us the wrong information. The information we need from our plumber is what the bill's going to be and how long the fix is going to last, and whether he needs to knock a wall down or drill a hole in the wall, or whether he's going to put a yellow boiler in the middle of our front room. Those are the things we need to know. So if he tells us he's going to fix our manifold sprocket, I don't know what that is, by the way, and then we come home to find he's knocked a wall down, put the yellow boiler in the middle of the living room, and presents us a bill for £5,000, suddenly we would have wanted him to involve us in that decision. So actually, you're right. We do just want the plumber to fix our central heating. We want his expertise, but we do need to know the implications of the decisions he's making. And that's a really key point. When we're making decisions with patients, it's important that they understand the implications of what we're saying. Because a lot of people, and those of you who are involved in MDTs, will see that you often have an MDT meeting, which then delivers a recommendation to a clinic. So the patient is here, met in clinic. I don't know if you can see my pointer, but anyway, I'm just pointing to the bit that says patient. The patient is met in clinic. The MDT meeting produces a recommendation which is sort of delivered into this MDT clinic setting. That's quite difficult to marry up with shared decision making, because in that model, a patient really has the job of either accepting or rejecting this recommendation. It's very difficult to reject a recommendation. And if you do reject the recommendation, then what? On what grounds have you rejected it? And what next? What other things can be offered to you? So how that MDT functions and how it delivers that recommendation is key. And to move the conversation on a little bit, I want to talk to you about values. Now, if you want to, and you've got a pen and paper in front of you or something you can write on, then it helps with this exercise. If you haven't, then just do it in your head. But it's quite straightforward. I want to take you through a piece of work that I did a number of years ago. Now, I described 4 health states, as they're called. These are 4 situations that patients might find them in after they've had treatment for head and neck cancer. On the top left is the total laryngectomy optimal. So those are patients who have had a laryngectomy, have removal of their voice box and are doing well. Total laryngectomy complications, they've suffered complications and are suffering the side effects of that. And then bottom left, chemoradiotherapy patients who've had chemoradiotherapy and it's going well, and chemoradiotherapy with complications. So I'm not going to go through those health states, but I'll go into a little more detail in the next slide. But essentially presented these health states to 3 groups of people and asked them to value them. And I'm going to take you through how we ask them to value them, because I think the process of valuing these health states makes you understand helps you to understand what it's like to be in them. So here we have a time trade-off game board. And I want you to just look at this and get your head around it. So on the left is a patient, top left, patient had a laryngectomy. Top right is a patient who is you today, normal health. Current health, you could call it normal health or current health. So where you are today. The patient on the left, you can see, has a permanent stoma in the middle of his neck. He breathes through that. He can swallow. He's about to do a swallow test, you can see. He can swallow a reasonably normal diet. He probably wouldn't be able to have burger and chips, but he would be able to have, for example, sort of a cottage pie or something like that. So you can't eat everything on the menu in a restaurant. He speaks by covering that hole and forcing air out through the mouth. That speech sounds different, but it is he's able to get his message across. He can't use hands-free speech. So I want you to imagine that health state. And I want you to imagine that you're sitting in front of a doctor and you're trying to work out whether to enter that health state or not. Today is the day that you have to decide. I don't want you to create some hypothetical future for yourself where, you know, your kids have left home today. So, you know, whatever situation you're in today. And so if I offered you 10 years of life as a laryngectomy or 10 years of life as you are now, then which one would you take? I'm hoping that you would all take life as you are now for 10 years rather than life as a laryngectomy for 10 years, because you'd prefer to stay out of the not to have a laryngectomy. So how about if I said to you, you can have 10 years as a laryngectomy or you die tomorrow? It's not a painful death, you just float away. You disappear, evaporate off the face of the earth tomorrow, or you can live 10 years with a laryngectomy in the health state I've just described. Now, some of you might think, well, actually, I'd prefer to die tomorrow than have a hole in my neck and not be able to speak properly. Whereas some of you may say, no, I'll take 10 years, thank you, because I'll be willing to put up with those things in order to give myself 10 years. So then I might say, well, what about if I give you 5 years with a laryngectomy? Sorry, 5 years with your health as it is now, or 10 years as a laryngectomy. It's like five years normal health, 10 years as a laryngectomy. And then I can alter the amount that I give you in your normal health in order to avoid laryngectomy. So it's always against 10 years as the health status. So 10 years as the laryngectomy, or 7 years as you are now. Now, for some of you, you might say, no, I just need a year of my normal health to avoid 10 years. Whereas some of you won't want to sacrifice really any of your life at all, and will say, no, even 9 years, I'm not willing to sacrifice 1 year to avoid a laryngectomy. So the number on the right here will vary between you. And then we repeated that for this patient here. This patient's had chemoradiotherapy. She can see she's had quite a bad reaction. Let's say that she ended up in a position where she couldn't take anything by mouth because she's aspirating. She's fed solely through a PEG or gastrostomy tube, which goes straight into her tummy. Her voice is produced normally. She can breathe, and she can use her voice as you would use it now, except it sounds quite hoarse. But her swallowing is very poor, and she can only really, well, she can't take anything by mouth and is fed solely by PEG or gastrostomy. And then you go through the same process again. Well, how does that sound to you? You can produce your voice, but you can't eat. And some of you might say, if we went through the same process, might say, no, I'd rather die tomorrow to avoid that because I wouldn't want to be null by mouth. Whereas some of you would alter the amount that you would survive, or the number of years that you would trade off in order to avoid this. If you've got your head around this concept, and I know it's difficult to get your head around until you've done it a few times, but write down the number that for you would have to avoid that health state. How many years of survival, normal health for you is equivalent to 10 years in this health state, and the same for the health state before. Now, what you do is take that number of years. Let's say you settled on 7 years of your current life. It's equal to that health state. Then you put that over 10, which is the total number of years you could have had, and that comes out with a number. In this case, it's 0.7. Now that's called a utility value. And a utility value is a number between 0 and 1, where 0 is equal, you're saying that health state is equal to death. And 1 is saying that health state is equal to current health. Now that's a reasonably blunt tool, in that it's just a number. It doesn't really purvey a lot apart from just how roughly bad or good you see something as being. But it's useful because it can be transferred between health states. And I think it's a useful exercise to go through to help you to understand how bad or good you see something as being and put yourself in the position that a patient finds himself in. The first thing I want to say is that when we look at the utility values between groups, they vary, but they show patterns which are reproducible between studies. The green line here, this is 3 studies of results. The green line are controls. So these are controls as in people who are similar to a first presenter at head and neck cancer clinic. So these are COPD patients. Now, remember, the lower the number is, the worse they see the health state. The higher the number is, the better they see the health state. Chemoradiotherapy, total laryngectomy with complications, chemoradiotherapy with complications. And you can see quite consistently the controls are valuing all the health states worst. They're seeing them and thinking, oh goodness, I don't want that. The patients are in the middle and the staff are at the top. So the staff see the health states as not being as bad as the patients. They think they're a bit better. Now, this is something we've found before. Staff often overvalue health states and see them as being not quite as bad as they are. Controls tend to undervalue health states because they've not been in them, and patients are in the health state they're experiencing at the moment, so they've had some time to get used to it and do the mental processes required to at least think about ways of making their life better or ways of making their life manageable. So they tend to value the health state slightly better than controls. But the other thing is the variation. You can see there's a huge variation in the value that patients and staff, this is patients, but this is the same for all the studies. There's this huge variation in how individual people value each health state. And that's not a huge surprise, because some of you will, I can't see you, but some of you might be 60 or 70 years old, and some of you might be 20 or 30 years old. You might have family at home, you might have family away from home, you might be due a wedding, you might have a dog, you might enjoy eating out, you might enjoy eating in, you might use your voice for your work, or you might not speak much at all. So each of you will value the things that we're valuing here in different ways. Now, when we're delivering recommendations to patients, we're essentially saying to them, we're going to put you into this health state. So, for example, if you have chemoradiotherapy, if it goes well, you'll end up like this, and if it goes badly, you'll end up like this. And if we say you should have an operation, then you know, if it goes well, it goes like you end up like this, etc. Now, so that's what we're doing. We're making decisions, but really we're delivering patients into a health state of some form or another. There is some uncertainty as to which health state they'll end up in, because we don't know whether they're going to have complications or not. But what we need to do is talk to them about the health states they're going to end up in. We end up in clinic talking a lot about the process of care, how long the operation will take, how long they'll be in hospital, how they'll get to and from the hospital for their radiotherapy, the transport that they'll use, who'll look after the dog during the treatment. Those are the sort of things we end up talking about. We talk less about the implications of the treatment decisions, whether they'll be able to go to a restaurant in a year's time, whether they'll have hands-free speech, whether they'll be able to go out for a walk, or whether they won't want to. But the key point of this whole talk is that patient values should inform our decision-making processes. It shouldn't be our values that are driving this. We use our values when making treatment decisions all the time, and we should be aware of that. We often place a higher value on health and good health than we do on other aspects. For example, a simple example is, it's difficult when you're not here, but smoking or drinking. Let's say smoking, so that's easier. It's bad. Smoking is bad. Stop smoking. We should all stop smoking. That's a value that we've put on this situation because we feel that smoking is going to put you at risk of future health problems. And that makes perfect sense. But at the same time, if smoking brings you a lot of joy, then that might be something that patients value more. It doesn't make sense to us. We don't even agree with it. But it's not whether we agree with it. All we need to know is whether they understand the implications of the decisions they're making. Smoking is clearly bad and people shouldn't smoke, but I'm using it as an example of how actually values drive things that we do. Because sometimes we value long-term health above all else, whereas a patient might value today more than anything else. So the PhD, I've got 20 minutes left, so I'm going to talk a bit more about the actual discussions that people have in clinic. The PhD was looking at this pathway that I've just shown you: cancer diagnosis, then a patient has a clinic appointment, then they have treatment, then they go into the recovery. 3 to 6 months is just a lie. It's more like 2 years at least. And the MDT meeting feeds into this. So what I did is I observed, so audio recorded and word for word transcription of this setting and this setting, and then interviewed patients here before the treatment started, and then again in the recovery period. And then I also interviewed established patients and staff members. I want you to just appreciate that. That took me about an hour to get that movement there. So you can all appreciate the movement. It probably doesn't come across on the web. So that was done over 3 centres, lots of different meetings and interviews and those sorts of things. And I'm going to show you some data from the MDT and some data from patients and what they said during the consultation and to me as a researcher. So we're going to talk about treatment choice. So this next snippet is taken from an MDT. Hope you're keeping up. We now are being transported to an MDT in head and neck cancer. So there's about 40 people in the room. They're discussing a patient called Samuel Belton, not his real name. He has a bulky cancer of his tonsil, and he has the options available to him of major surgery or chemotherapy and radiotherapy. There is uncertainty within the team as to which of these would be best for him. And the point at which we join the MDT, this is real data from real patients, is the point at which they realise there are two options available for this patient. How should they proceed? I'm going to read it out to you. The max-fac surgeon says, shall we see him together, i.e. him and the oncologist? Silence for 10 seconds, which is a long time in a room like that. ENT surgeon, depends how you put it to the patient, isn't it? You know, plastic surgeon, it's one of those things. We've done this before. You see the patient, you have two people there, and you confuse the patient even more. I think, nurse, it's horrendous. I think it's the worst thing you can do for a patient. I agree. I think it's a terrible thing. Patients just don't know. They don't know what to do, but we're not supposed to give the patient choice. So you can see they're arguing there, not over which treatment they should deliver to this patient, but which choice, whether to give the patient a choice or not. Now, you may agree with one or two of the speakers there, or none of them. You may have strong feelings. But the fact is that this conversation took place. And instead of saying whether it's right or wrong, I'm going to talk to you about why conversations like this arise. So firstly, the members of the team have a very clear view of what they feel is best in any clinical situation. This is from an interview with an oncologist. In general, head and neck cancer, there isn't an option. You've got the best treatment and there's an evidence base for that. Once you've decided on that option, it's not that I'm deciding it as a non-surgical oncologist or a surgical oncologist deciding on it. That is a truth as far as we know it. That is at present universally thought to be the best treatment for the patient. So it's not a case of choice, it's a case of a patient accepting a recommendation in his opinion. Now, if one best treatment is decided by the team, i.e. chemoradiotherapy or surgery, this one treatment option may well then be delivered to the patient. If there's a choice between two options, there's often framing goes on in the clinic room in order to make sure that the correct decision is made. Now, framing is essentially the alteration of your description of a treatment. So to demonstrate framing, I'm going to show you two descriptions of radiotherapy to the head and neck. This is both by an oncologist. This is taken from the clinic appointment. So his description of radiotherapy: your skin on the outside will start getting red like it's had a sunburn type reaction, and on the inside, and it starts getting red and inflamed as well. And that means you'll start having problems like a sore throat. So you'll be put on special mouthwashes. You'll feel more poorly if you're not keeping your strength up. So we would arrange a little tube that's put in your tummy. So you can see this patient's had a sunburn type reaction, sore throat, special mouthwashes, little tube. This is generally, a lot of things are underplayed. You can see that this oncologist wants this patient to accept the treatment and is trying to underplay the side effects that they might suffer. This is another description. The outside of your skin and the inside of your throat will all become quite red and hot and sore, and that's why swallowing will become very, very difficult, probably impossible. Even swallowing your own saliva will be impossible by the time you get to the end of that 6 weeks. Even the strongest guys struggle, believe me, and by the time they get to 6 weeks, life is very difficult. Infection gets into your throat, no problem, and you're overwhelmed. So this is a very different description. Can't follow their own saliva, swallow their own saliva. Even the strongest guys struggle, you're overwhelmed. So this patient turned this treatment down, not surprisingly. Now, neither of those oncologists are lying to their patients. Some patients experience the first description, and some patients experience the second description. But the point I'm trying to make is that the way you describe a treatment option to a patient has a huge impact on whether they accept it or not. And sometimes we can have this sort of situation of pseudo treatment choice where we pretend we've given a patient choice, or we talk a patient through treatment options, but you can tell quite clearly from the way in which the options are described, that the clinician has quite strong views. But why is this a problem? As I say, if you've got a group of experts who are trying to decide what's best, then why not just deliver that to a patient? Well, as I've said already, the reason is because of patient values, opinion. Now, there isn't often a best. Things change. New research comes out. Something might be better for local regional control or survival, but worse for quality of life. And that depends on whether you value quality of life over long-term survival, or whether you are willing to take a risk on a treatment which gives you more chance of long-term survival but might kill you if you accept it. Or you may take another route where the cancer will definitely shorten your life, but you're pretty much guaranteed more than 6 or 12 months. And those sorts of decisions come down to values. They don't come down to clinical opinion. Now, the uncertainty and difference of opinion is often seen as something which would remain backstage. And backstage, what I mean is that's the MDT. The backstage area is where the MDT discuss where the patient isn't. And that backstage area is important because that's the area where we voice our worries and our stresses and our concerns about treatments. And we negotiate which treatments are available and which are going to work and which aren't going to work. The problem with bringing a patient into that space is that actually it means that the backstage just moves, and people have those conversations in corridors and offices and by email, and that fragments it. But uncertainty is seen as a thing that should be hidden a lot of the time by a lot of people. I really do not believe it's fair to say to the patient, we're quite uncertain, we don't know what to do, these are the options, what do you want? Excuse the language, sorry. That you're the expert, that's what they're paying you for. They can't walk away thinking, Christ, that even the experts don't know what to do. That's desperately wrong. That's a maxfac surgeon, not known for they're known for their straightforward. If any of you are maxfac surgeons or know them, you'll know they're known for their straight talking. The other thing is that choice may exist at the group level, i.e. there's one individual who thinks this is best and another individual who thinks something else is best, another individual who thinks something else is best. So choice exists at the group level, but there isn't actually one individual within that group who feels that both of the options are equally available to the patient. So for example, if clinician A thinks that radiotherapy is best, and clinician B thinks that surgery is best, whether you choose physician A or B to deliver the choice or the discussion to the patient affects which choice that patient is going to make because of framing. And this is something that's voiced in the MDT meeting. We know that even when these patients are presented in the clinic, they're presented in such a way that he'll probably go for surgery if you're seeing him. And if I was seeing him, I guarantee he'd have radiotherapy. But this can mean that a lot of the work of decision making takes place in the backstage, which will also exclude the patient. And this can mean the patient's absent from the decision. But people don't want the patient to be absent from the decision. Clinicians don't work like that. We don't work in a paternalistic environment anymore, and we don't want patients to not be included. So we bring more and more and more evidence into that backstage in order to try and build what I've called an evidential patient. So, for example, you might say he's got a good support network, or he talk about the hobbies that the patient's got, or that they've got a dog, or any amount of information. And different MDTs do this in different ways. But it's difficult to incorporate that kind of information into a decision, which can then be delivered to the patient. So, for example, if he's got a good support network, does that make you more likely to treat him radically or palliatively without making a judgment about them? Personally, I know I would like to be represented by myself rather than a vignette about myself, which could be on which to base assumptions. So this is a speech and language therapist. You're just making decisions based on scans and guidelines as opposed to an individual and having somebody having had the opportunity to explore not just their physical and psychological status, but their feelings about treatment. It would be nice to have much more of a feel and a knowledge of the patient before it gets to that MDT. But the problem is we do struggle sometimes to include any of the information than clinical. And it impacts on any assessment of best interests. And it also means we don't know how involved the patient would like to be. Now, some of this data is quite old now, and it's demonstrating points which probably still exist in a lot of MDTs, but in the MDT that I'm in, I don't think no longer do exist. And I think one of the reasons for that is this idea of best interests. We are not in that MDT room to decide what is best for a patient, because what is best for a patient depends on a lot of things other than necessarily maximizing their survival, which is what we talk about a lot of the time. So we are not there to decide what is best. We're there to decide what options are available, what options are willing to deliver. Is the oncologist willing to deliver to radiotherapy? Is the surgeon willing to do the surgery? The decision about which of those to choose is to be made with the patient. But if we come back to this from Samuel Belton at the start, shall we see him together? When you break it down, you can see that actually, shall we see him together, depends how you put it to the patient. That's acknowledging framing. And it's horrendous. It's the worst thing you can do for a patient. It's a terrible thing. They're talking about abandoning a patient and saying to them, well, you decide. It's talking about uncertainty and how we deal with uncertainty in clinic. And even though in this short snippet of 1 minute of conversation, patients mentioned 6 times, but none of these people at that point had actually met him. So I've just spent a couple of minutes talking through the patient side of the decision, and then I'll stop. So this is a patient who's got a decision to make between a laryngectomy and chemoradiotherapy. So it's the same decision that I was talking about in the time trade-off game boards. He had that decision to make, and this is his view on it. They're the doctors, they're the professional people. I'm just Joe Bloggs off the street. I mean, for a lot of years, I was a steel erector. I wouldn't expect you as a doctor coming along and doing what I could do I? You feel a decision should be the doctor's decision. Oh, definitely, without a doubt, it's got to be the doctor's decision. How could I make a decision like that? Now, when you hear that, how could I make a decision like that? Is that him saying, well, you just make the decision for me, as he's saying there? Or is that a patient who has no access to this decision? Has he seen a clinician who has talked to him about the overhead manifold sprocket and the way the central heating works, rather than talking to him about the implications of the treatment he's making? Because he does have a role in that decision about whether, for example, he breathes through a hole in his neck or not, or whether he has a gastrostomy or not, and whether he gets admitted to hospital for 2 weeks or stays as an outpatient. Those are things that he will have an opinion on. So perhaps that patient, it's not that he's saying to us that you make the decision for us, it's because we haven't given him access to the decision. But what it creates is this cycle of paternalism where you have grateful patients who don't have any access to a decision because they don't know the ins and outs of the implications of the decision they're making. And you've got a group of doctors and nurses who are doing their best and accept these grateful patients, well, just tell me what to do, as instruction to just tell them what to do. But the problem is patients don't always act like that. And sometimes they turn down treatment options or refuse treatment options or exercise their right to have control over a decision. This patient, I'll let you read through this. This patient is clearly turning down surgery, and and that is probably his only chance of long-term survival. So he's turning down his chance of long-term survival in order to try and try radiotherapy first. But in doing that, his chance of survival is very diminished. Now, that may well be a choice that he wants to make, but when I talk to him about why he made that decision, I'll let you read through his words. It's quite clearly survival is his main the main reason for making his decision is surviving as long as he can. He's turned down that treatment option based on what can only be misinformation. Surgery doesn't work for cancer. So, as much as it may well be perfectly reasonable for him to make that decision, I think the two things we learn from this patient is one is that patients do have controls over their decisions, and secondly, some of the information that they base their decisions on might be wrong or might be misinformed. And part of dealing with patient choice isn't just to accept what patients say at face value, but sometimes to challenge what they've got to say, or re-instruct them, or have a conversation with them about how you might not agree with what they've got to say, and say that. But it means that we have patients who have lots of control over the decision, which they should. If we don't inform them properly, they have to go off limited in experiential information, so their own experience. So unless we do patient involvement properly, we shouldn't do it at all. Not doing it at all is morally not really an option to us, so we're duty bound to do it well. So we need to understand more about how patients make their decisions. How do we help patients? We know a lot about our own process of decision making at the top. But how do patients make their decisions? Well, firstly, we know that patients distribute decisions. They don't make all their decisions in the clinic room, which is not a big surprise. If you walk into a car garage, you don't point at the first car you see and say, "I'll have that one, please." You might, but you probably don't. You probably think about the sort of car you might need and what you might need it for, how much you've got to spend, whether the car's good, how long you're thinking of keeping it for, whether they have a warranty. You might read some reviews, you might take it for test drives, you might talk to a friend who's got one. That's distributed decision. You take different bits of information from different people, you value them in different ways, and you use that to piece together a decision. We do it. We have an MDT meeting, but we've had time before that in order to look at the scans and have a think and look up the latest evidence, and then to have a chat with a colleague or somebody else, and we've gone to an MDT. So we've done it. We distribute our decisions. We should be allowing patients to distribute theirs too, because when we do, and when I do as a clinician, I find that the second consultation, after I've allowed them a bit of time and space to sort of mull it over, is so much more worthwhile than the first. And sometimes that involves saying, right at the start of the consultation, we're not going to make a decision today. We're going to make it next week. And it sort of takes the pressure off the consultation. It makes a consultation shorter, in all honesty, because you're able to say, these are our options, radiotherapy or surgery. The MDT thinks surgery because of this. That doesn't mean radiotherapy is off the table. They think not radiotherapy because of this. But the implications of that is this, and this. Now, we're not going to make a decision today. I'm going to give you some information about having surgery and having radiotherapy, and you're going to go and speak to the nurse after this clinic appointment, and then I want you to spend the week at home or a few days at home speaking this over with your family. And then in a week's time, we'll come back and we'll revisit this decision, and then we'll make a final decision then. And once you've set those ground rules, the interview goes a lot better. I'm just going to skip through those. What I'd like to just finish on, because we've got a minute left. MDT working is the standard of care. It is a popular way of working and it's here to stay. we need to do some work if we want to involve patients properly in this process. And the structure of delivering a recommendation into a clinic room actually makes patient involvement quite problematic. We can't not involve patients. We need to consent patients and talk to patients in a way which is a two-way street in terms of information giving. That means telling them about the treatment options that are available to them, but then listening to their values and preferences and listening to what they've got to say back to us about whether they think one is better or worse. And we need to develop ways of asking questions as individuals and as groups to try and encourage that. What's your priority for treatment? How involved do you want to be? What do you think of what I've just been talking about? So instead of this, perhaps we could do something a bit more like this, where the staff work, the MDT decision making, produces a recommendation, but the patient work, which is supported in the same way, produces a preference. So this patient work doesn't have to take place after the MDT, it can take place before, it can take place after the diagnosis. And then this is where decisions are made in the interaction. The recommendation or what the MDT thinks is combined with what the patient thinks. And this interaction is where we do the work, and that happens between the patient and one or more clinicians. Okay, thanks everybody. I've 1 minute over. Thanks for listening, if you were.
Thank you so much, Winnie. Yet again, it was absolutely fantastic presentation. I've had some feedback off a couple of people as we've gone through via text who were listening and have said exactly the same. It's, I hope you don't mind, but I'm going to send your picture live because you went to such sterling effort with your Christmas tree. So everybody can see. I'm sure they will very much appreciate the Christmas tree lights that you put on for everybody in the fire that you lit, because it's a magical scene. There are a couple of questions. And if you don't mind, just to keep us to time, I'll send them to you and we can put that on the website along with your presentation that people can access a little bit later when we've had time to get everything uploaded. Is that okay?
Yeah, of course.
Brilliant. So it just remains for me to thank you again. You've been an absolute star. Not only the content, but your style of delivery it's so engaging and so wonderful to listen to. And a big thank you to all the delegates, because we've said the same every day this week, that it's not been taken for granted the time that people have put aside to attend these events. We know at the moment, more so than ever, time is really pressurised for everybody, including yourself, Winnie. So thank you to everybody who's on the call today. It's very, 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 very much appreciated, and enjoy the weekend, everybody.
Well,
goodbye.
Thanks for having me. Thank you.
You're welcome. Thanks. Bye. Bye, Winnie. Bye, everybody.